Good afternoon and welcome. Welcome to the second session for the MediWales Connects NHS Collaboration Conference. This morning we had our first plenary session, which was an absolutely delightful mix of innovative projects, aspirations to do more and do better coming out of the COVID pandemic, and examples of where organizations, public, private, charity sector, academics have all collaborated to achieve great successes. So it really was a pleasure to be present in today's morning session. So I'm very much hoping that for the next 4 days we're going to replicate that over various topics and various themes, and we're all going to really come away from the Connects conference with a clear understanding of just how much effort has gone into not only managing the COVID pandemic, although that has been a mammoth task and something that everybody in healthcare should be very, very proud of, but also in developing innovations and planning for the future, and in creating new infrastructure and new projects that will keep things on track for the coming year. We're going to see recovery projects, and we're going to see adoption of new technology and digital transformation on a scale that we've not seen before. So really exciting opportunities for the future. Now, part of that is our research community, and that's what this afternoon's presentations are focusing on, living research. And I'm really pleased to see the teams of researchers that we have presenting today, and I know some of them very well, and I know that they give superb presentations and are very both interesting and informative to listen to. So I'm really looking forward to this afternoon's session. Just a couple of housekeeping things. Hopefully, if you were in this morning's session, you heard me talking about Meeting Mojo, and hopefully you've had an email from Isabel with your Meeting Mojo login included. If you haven't, then please just drop us a line, drop Isabel a line. Then, so Meeting Mojo is our platform for one-to-one partnering. So in addition to these seminar presentations and workshops that we're running on Zoom this week, we're also giving everybody the opportunity to upload their profile and to request and schedule one-to-one meetings with each other. So, so please do engage with that to get the full value out of your Connects conference week. A request to our speakers: we're okay for time today. It shouldn't be too rushed to get through our presentations on time. But that being said, this is the research session, and I don't think researchers are known for providing short, punchy presentations. So that's so just a little request, just to try and keep to the schedule that we've arranged, and hopefully then we'll have an opportunity for a bit of Q&A, and hopefully we'll be able to finish the program on time. So. A request to delegates, all of those of you who are observing, watching today, please use the chat. Please use the chat function and the Q&A function. If you've got questions, please put them in the chat or the Q&A. You'll notice that next to your name, there's a little blue box in the chat, and that specifies whether or not you're making your comment just to the panelists or just to all attendees. So you have to click that to all attendees in order for you to talk to the room. And I really would encourage you to. It doesn't have to just be a question. It doesn't have to be specifically about the presentation. It could be an introduction. You could just be saying hello to the world. We all need a little bit of that at the moment, and it really helps the speakers as well to know that they're not just talking to their laptops. It is a strange environment to be speaking at a conference in, and a little bit of interaction, a little bit of feedback always helps. On that same theme, Twitter. We are using Twitter in our usual way, and there's already been some great feedback on Twitter. Our tag for for tweets about the conference are at MW Connects, and please do use that that handle so that we can track your comments, and so that we can share, reshare, and get them out there to the world. That's another great way of everybody interacting. And please just enjoy the next couple of hours, and I do know that the presentations that we've got are excellent, and you'll want to sit back and enjoy those, as well as engaging through the chat, through the Twitter. So on that note, I'm going to stop speaking, and I'm going to hand over even to our first speakers, and I believe we are going to have Keir Lewis and James Ingram, and I'm just waiting for them to log in as we speak. James, I can see you. Are you there? Can you turn your camera on and turn your microphone on? Hello, James. How are you? Sorry, James, still not hearing you. I'm not sure why that is. Maybe it's my end, but my team will tell me whether we can hear you if you just give us a couple more comments, James. No, we can't hear you, James. So, James, I'm not sure whether you're speaking at the moment. I'm going to give you a couple of seconds just to try and sort it out at your end.
How about that?
That's perfect. Excellent. Thank you very much.
Is the screen sharing working?
The screen sharing is working fine. So we don't have Keir on screen yet, but if you are, so Keir has now sent us a message saying it's online. So with a couple of glitches there, as we always have at the beginning of the seminars, I think we're ready to go. And James, thank you very much. I didn't introduce you properly. It's Science and Engineering Applications Limited, and you are a director. So I'm now going to hand over the floor to you, James.
Smashing, thanks very much. And I'll actually hand over straight to Keir. I know Keir's just out with his patients, so thanks, Keir, for coming. Keir, if you won't mind, I'll drive the screen, and you please introduce.
Hello, I hope you can hear me. Yeah, if you can nod, if you can hear me, James.
Yeah, no problem.
Great.
Yes,
okay,
thanks.
so
Keir, we can hear you.
I'm Keir Lewis, and I've just come from the ward, so apologies. So we're going to talk to you a little bit about our long COVID tracker. If we can have the next slide, please. So most of you already know that long COVID is a massive and growing health burden, and we're all part of this NHS, and the NHS literally is now on its knees, as well as trying to catch up with all the other things and deal with the staff who are quite beaten up at the moment. What we need to do is look at new deliveries and models of care that really fit with the prudent healthcare principles, but also meet this new and growing demand of what is called currently called long COVID. We have a next slide, James. We know increasingly that long COVID can be up to 200 different symptoms. They're variable, they come and go, some are quite severe. We do think it's more common in hospitalized patients, but the vast majority of people being referred at the moment, about 85% of people who weren't never hospitalized with COVID, but still have positive antibodies or positive swabs and were unwell at home at the time. If you look at the European data, if we go back a slide, sorry, the main symptoms are fatigue, breathlessness on exertion, and brain fog. The commonest persistent symptom seems to be altered loss of taste or smell. And unfortunately, I've got I don't enjoy red wine as I used to. I can't taste it so well, would you believe, since my infections. But luckily, I don't have some of the other things that people have complaining of and are progressing with. If we go to the next slide, please. What we hope to do and what is being done at scale is we do think that the more you have the illness, it does actually fade in time unless you were ill for a long time in the beginning. But symptom scores and severity don't always improve over time. And some fluctuate, some get better, some don't. But how on earth can we sort of sift through multiple people with multiple symptoms when we get referrals from GPs or primary care or other healthcare providers saying, please see this person who is breathless and dizzy and has a brain fog? How can we gauge these symptoms over time and see if they change or not? If we go to the next couple of slides. And again, going back to the sheer numbers, we think maybe up to 12 million people have had COVID, look like they've got that infections. And even if you look at 10% suffer from COVID, we're looking at over 1 million new people with symptoms ongoing in the UK alone. Of the 450 that I've seen and discharged from hospital in wave 1 and wave 2, I currently can see only 5 patients per week due to clinic restrictions and other work and catching up with lung cancer work. So of those 450 people, I'll be lucky if I can see the next 10 to 15 people in the next 4 months. And these are the people who were hospitalized with COVID, who were ventilated with COVID or needing CPAP machines and high-dose steroids. And there's increasing evidence that once you even hospitalized and discharged with long COVID, up to 1 in 3 are now coming back into hospital with symptoms. And some people believe up to 1 in 7 people are dying within 6 months, which is very worrying. So this is a prevalent condition that we don't know enough about, but we're still trying to learn. We'll go to the next slides. The only thing that we're trying to do is really go back to the Welsh written statement that came out earlier, well, last week, to draw upon expertise, but really we cannot cope with the sheer numbers. And I think using this value-based kind of pyramid, if we go back to using patients or citizens themselves to monitor their condition themselves, their own data themselves, and choose to share it with GPs or share the data directly with specialists, then it becomes almost manageable, rather than direct referrals back and forth between specialties. I mean, if you're trying to design a long COVID service, where on earth do you start? What specialists do you need? How often should they meet? So tracking this condition over time is one of our priorities, and using a triage system model that's prudent and manageable. Okay, next slide. So there's lots of recommendations to get better research and get better understanding. And one of the other things we all know as well is that COVID makes inequalities worse. So if you are vulnerable, if you are targeted, or if you do live with other people or you've got other conditions, you will suffer more. And those kind of people and people, ethnic minorities or people from social difficulties, social backgrounds aren't going to engage anyway. So these are the kind of people who will suffer and get COVID. So hard to reach groups, multiple groups, but really patients and citizen self-management and tracking themselves over time. That's what we need. So next slides. And again, lots of questions the Welsh Government are asking us, but how on earth do we find these people? How on earth can we monitor them over time? Well, we can use technology to do it. What symptoms do fluctuate? Do they get better and do they get worse? Can someone be signposted to the right place if they had the appropriate symptoms? Do they need to see a lung doctor? Do they need to see a neurologist? Do they need to see a cardiac doctor? Are these symptoms getting worse or are they improving? And hopefully this monitoring system can help us develop that. Next slide. So I'm going to hand you over to James to talk about the app, and this is the kind of things that we hope we can develop with people over time.
Thanks, Keir. I think the points Keir are raising, you know, when you listen to some of the really interesting discussions going on this morning and all the good work going on, then you look at what's needed for long COVID. We need to apply all that thinking and effort to this particular condition because the numbers are huge and we're not really ready for it across the UK and internationally. So we've been working with Keir, and this came from the Welsh Health Hack early in the new year. In fact, it was just the end of last year when it was awarded to us with Hywel Dda. And it was to try and come up with an app that could address all the problems that Keir's just been talking about. A few of them are mentioned here. And it's about getting data really quite quickly. It needs to be very fast to implement. We've got a lot of different systems that we need to interface with, so it needs to be very simple and quick. And also, it's a two-way thing. It's not just about individuals, some of which aren't patients yet, providing data to their clinicians and other specialists. It's also about trying to signpost the individuals involved to the right sort of services that are local, because we can't have everybody just phoning their GP or phoning the likes of Keir. So it's two-way information there, and clearly as well, it's about gathering statistics based on symptoms in local areas to understand what the services are going to need to be moving forward. So that's what we're looking to, well, that's what we have finished now. So I'm going to talk a little bit about the app we've developed. It's really all about making it easy for patients, and as Keir was mentioning there, it's also looking at some of the hard to reach individuals who may be vulnerable, or in the communities that don't typically engage and use self-reporting apps. In fact, not a lot of people use self-reporting apps for chronic conditions. So we put it on two platforms, and I'll talk in a few moments about the community platform we're using, but the aim of this diagram here is to show that it could be somebody else helping the person record their symptoms and helping them then refer that information on to their doctor and onwards to the rehabilitation teams looking after them. So the first platform we put it on is an app called Chai Community. This has come from an app originally developed with two health boards in Wales, which is the Chai Professional Platform, which is an electronic patient record system for acute care in hospital. And when COVID kicked off last year, we thought there was going to be a large demand for care in the community, so we adapted it away from acute care plans to chronic care plans, and away from trained nurses to volunteers, friends and family who can help individuals record their chronic conditions. At the time, we weren't thinking specifically about long COVID, didn't know about it. It was designed not just to help people manage organizing shopping and that sort of thing for people in need who may have been shielding, but also to help them track their chronic conditions. So when we became aware of the long COVID issues and concerns, it seemed the logical place to put it. But also there's an awful lot of people who can self-monitor if they have to. And so we've had a standalone app, the Long COVID Tracker.co.uk app, where it has exactly the same symptoms trackers that are contained within the Chai Community app. And there, as Keir was saying, we've got just short of 200 symptoms that people can record the severity and the frequency of the symptoms, along with any other conditions that could be influencing how they're getting on, whether it's returning for work or other things affecting their life. They can make a note of that to help their clinicians understand their condition. But also critically as well, it's got information there about when they contracted COVID-19 and what vaccinations, if any, they have received. I think there is some evidence starting to come out that vaccines may be helping some individuals with long COVID. I'm not an expert in that, and I think we need more information on it. So there's definitely need for research in that area, and this app can gather that data. I was saying earlier that the key thing is to make it easy for anybody to get hold of the data if they need it. So working with Keir and the team at Hywel Dda, we have now developed an app for clinicians or any trusted person by the data owner to be able to access their data. And essentially what happens is when the individual using the long COVID tracker or the Chai Community app, they're able to open a sharing session, which gives them some access codes that they can share with their clinicians, who can then put that information into the Download My Data app and see the data. It's all done obviously in a very secure way. I think just coming back to Keir's really powerful points about the fact that there is too many patients that can be seen by GPs and specialists. There's a real need for good triaging, but also to enable people as much as possible to help themselves. And clearly the response of the health service to this is going to be changing, and the advice is going to be changing. Maybe new facilities are going to be opened. So there's a need to be able to get that targeted information to those who need it based on what their symptoms are and where they live. So that's what we're able to do with this app for health services who are signed up for the service. They can signpost any individuals, not just their patients, but any individuals in their region, and based on the symptoms, their messages will show up on the app to tell them what their next step should be if they've any concerns or want help. The aim here, of course, is to relieve the pressure on the frontline services. And the other aspect is the fact that, speaking with Keir, it's clear that he wants to know what services they need to be beefing up on to cope with the demand that's anticipated and is here now. And so the easy thing to do with this information once it's gathered is to provide it in weekly or monthly reports to explain how many people in the area are suffering and exactly what they're suffering and what help they need and what the severity of their symptoms are. So I think I mentioned just a few minutes ago, we've been doing this for a little while. We're doing it for a number of years, actually, with the NHS in Wales and also in Scotland. It's a logical extension from the inpatient app we had. And it's just pulling all the work over a number of years. So although it appears we've just produced something, it's actually a result of a number of years worth of work. And we actually started this road at the beginning of last year. Gwyn, how are we doing for time? I've got a 2-minute video here. Can we show it?
Yeah, you're absolutely fine.
Great. This is probably worth looking at just to put it in perspective. Oh, stop that. Okay, I'm I'm not entirely sure you could hear the sound on that. Kia was telling me that it may not have come across very well. Hopefully you got the message though. There's a lot of people who don't really know what's going on and really sort of reaching out for support. There are quite a lot of support groups now with one group I think has up to sort of 30,000 users on Twitter just talking about this condition because they really don't know much about it and don't know what to do about it. So it's fairly urgent, I think, that we're able to get to grips with this. And I think that's it, Kia, unless there's anything else you want to add.
No, that's fine. Thank you, James. Happy to answer any questions online or afterwards.
Smashing. Thanks very much. Sorry, it was a bit difficult to get going, and sorry for that sound didn't come across very well. I'm not quite sure what's going on there.
That's absolutely fine, James. No problem at all. I was actually sitting there watching it thinking, it doesn't actually need sound, so I wasn't sure whether it had sound or not, but presumably it did now that from what you've mentioned. If you want to mention it in the chat, then people could have a look at the link with sound in their own time. But honestly, I think it had. It was very well presented, regardless of the sound. So no problem there at all. Thank you so much for that presentation, and really nice to see the developments of the health hack from my perspective, because we participate and we've supported the health hack over the years, and sometimes you see the initiations of these projects and you see the collaborations come together between the clinicians and the technical experts on the day, but then they go off into the wilderness. And you hope you wish them well and you hope them the best, but it's really good to see you come back with a case study example of a project that's really benefited from that.
Thanks very much. We certainly had to go for it to get it ready for today.
Credit to James, he nags me and chases me down and says we need to do these things, but I think the company have done this at cost really for what they have done, and I do think it could be a model for many other diseases as well, which I think I can see one of the comments from Alan there as well, and I think it does fit with the prudent healthcare principles of pushing the data back, and you avoid all the GDPR issues by letting them have their data and then maybe choose to print a PDF of what they're experiencing in real time to who they choose. And I think that's important.
Absolutely, definitely. And empowers. I mean, we've had presentations this morning as well to show how collecting data. Sometimes it's felt that data pushes the actions back on the clinicians to actually do something with this data, but you've got an example there of where it actually empowers the patient to work on their own recovery. Yeah. And the clinicians then could triage the most needy or the most people who suffer or most quickly deteriorating ones, and use our scans for the right people. Excellent. Thank you very much.
Can I just say one thing? I noticed a comment there actually about the RHIG Wales app for long COVID. Indeed, there is. But I think that's actually more of a rehabilitation app. Ours is not a rehabilitation app. It's about recording symptoms and about messaging and providing that communication and statistics with the health boards. It's a different focus.
Thank you for that. If you guys would like to carry on in the chat for a little while, I'm sure there'll be a few more questions or comments that people would like to engage with you in. I'm now going to move on to our next presentation. We're staying with digital and we're staying with health art, but I think that's where the similarities end, although Fionn might be able to correct me on that. So if Fionn John, who is clinical psychologist and clinical lead, is ready and waiting, then I will seamlessly hand over to you, Fionn.
Let's try, Gwen. And hope.
We can all hope.
Okay. I should be with you there.
I think we're nearly there.
Slowly but surely. There we go. Okay.
Excellent. All yours.
Lovely. So diolch Gwen, and thank you MediWales for inviting me to talk today. You've got another Welsh health hack baby, actually. So following on from the previous speakers, Keir, and we've got, yeah, another something that's come into fruition from the inception of the Welsh health hack. So before I go any further, I would like to just acknowledge the team around me, which is OSP Healthcare. They're the digital company, our industry partner, who I think were as naive as us when we went to that Welsh health hack 18 months ago. My colleague Alec, who's the clinical specialist, or one of them with our service, who's been part of this all along with me. We co-developed and co-wrote the pain management program with service users many years ago, and it's sort of evolved and developed over time. And the Bevan Commission, really, for seeing something in what we were proposing and supporting us, and they've been a real sort of incentive to us, working through quite tricky barriers at times to bring this to something that's eventually going to help, hopefully, a lot of people. And picking up on what Caris said earlier today, support from the health board for us clinicians to actually engage in research is so important. And I think, however, we do it really well. I think we are an exemplary health board for supporting clinicians who have the drive to work in research and to do something with research and allow that to actually happen in quite an organic way, which is really good. And I feel very privileged and supportive to work for them. So why the need? Why need an e-learning pain management program, which is essentially what we've been developing for the last sort of year and a half? So adherence to all persistent pain guidelines would suggest that, a biopsychosocial holistic approach to managing persistent pain is what's required. And for that to happen really as early on as possible in the person's pain journey. Now, traditionally, it's all about sort of secondary care pain services, but we know that, we can't cope with the influx of referrals that are coming in, where, we do cover 3 counties. We've got quite a high demographic in terms of an older age population in Hywel Dda. We do have maybe less resource. So we are 6 core clinicians covering a 3-county, what is it, a quarter of Wales landmass. So it's a lot of work to try and reach all of those corners. And, we just can't do it in a timely way. And I don't think the traditional model of referring people to secondary care pain services is neither prudent or good enough, really. So we've been thinking about other ways of trying to target people's needs in a more timely fashion and in a way that might suit their ability to engage better. So before COVID struck, we were running pain management programs across the 3 counties. So we were running 7 programs simultaneously 3 times a year. So we were inviting in excess of 600 patients per annum to attend a pain management program. These were run over 10 weeks in person in community venues. So lots of traveling involved for us as clinicians, but also for patients to arrive to those community centres as well. 50% of those people that had agreed to come in quite an in-depth consultation clinic don't turn up, they don't engage. So they don't turn up for week 1, they don't turn up for the rest of the programme. So losing 50% of those 600 that are invited is quite a big chunk of people that's needs are still not being met. However, we're doing something right. So the retention to completion for those in-community pain management programs was high, 85% across the programs for 10 weeks for this cohort of people that are traditionally quite difficult to engage in any self-management work was quite high. And we're really proud of that. And of course, our data suggests this as well. So we're seeing increased self-esteem, increased self-efficacy, anxiety and mood are improved functionality and reported quality of life, and also their need to take medication. So our deprescribing rates are outstanding as a way of supporting people to better understand their pain, so that they become more empowered, I guess, to make make choices about their pain management. And I suppose they realise with education, with information, that medication isn't always what they need. So then our worlds were rocked, as everybody else was, in March last year, and we had to do something. Otherwise, we would be left with a huge backlog of people needing intervention, because we hadn't been able to offer that through the COVID period. So as we were redeployed in other services, we kept on working evenings, weekends to make sure that we could offer something to our patients as soon as we were able to work back in our services. So we came back and we developed a virtual pain management program. So it's the same team of clinicians, but we were facilitating our PMP on a virtual platform. And being able to invite, actually, so if we're running 5 simultaneously this time, so we've reduced the numbers of PMPs that we're running simultaneously, but we're still able to offer there or thereabout the same numbers of people to attend those programs, which is great. But of course, what was really interesting for me was the 50% was still not engaging. So we're offering something different. They don't even have to move from their home. They do need some tech to be able to engage, but we're still seeing those 50%, even though they've gone through the process of it being on a virtual platform, they've agreed, not attending. However, we're still doing something right. So over 90% on the virtual PMP are engaging with us and then completing the 10-week program, which again, I think is just phenomenal. And the preliminary data that we have shows that we're still seeing the same sort of positive outcomes as we would be seeing in face-to-face, which is all holding us in good stead with all the other background work that we were doing in the meantime of developing our e-learning PMP. So what about the disengaged 50%? We could just say, well, they didn't attend and they're discharged. And that's actually what happens on our systems. Operationally, that's what happens. But I was really interested to know why, what's stopping them from being able to engage? Because this isn't really prudent healthcare if we can just discharge people, because they will come back, because they haven't had the intervention that's deemed necessary for them to move on and make changes to their lives. So the most common reasons for not attending have been for both, actually, things like mental health. So an exacerbation of anxiety or not being able to engage in a group situation, again, can be really difficult for some people. Be that virtual or face-to-face. Even encouraging people that they can put their videos off and remain on mute as not being enough for people to be able to engage in that virtual platform. Face-to-face in the community, committing to a set time, exactly the same again with the virtual. Being somewhere on time was difficult. Committing to that sort of hour and a half, 2 hours was hard for people. In the community, transport is an issue. The language, so people would prefer it maybe in Welsh, that wasn't available as readily. It is available one-to-one, but not as readily in a group because of resource. Life getting in the way, and similar in the virtual, everybody being at home made it quite difficult for some people to engage on a virtual platform, because they just didn't have the privacy or the peace to do that with so many other people at home at the same time. And you can see there, the medication side effects was another common factor, and supportive employers not being able to give time for them to attend, even though they did have letters from us encouraging that to happen. So lots to sort of contend with. So what is the solution? Well, we have been busily developing a digital e-learning linear bilingual pain management program. So it's modeled on our good efficacy PMP, and it's developed so that people have to work with us, work through each module, encouraging that sort of engagement rather than quite a passive approach where you could just flick through things. You have to do things when you're engaging with this. And it's got lots of facets of learning styles. So there's the ability to hear, there's the ability to read, there's lots of nice visuals and storytelling in visual format, and it takes you on a journey, and it's fully biopsychosocial and holistic in its approach. And each module can be downloaded to work offline. So one of the problems was actually being able to access our virtual PMP in the meeting because they didn't have good enough connectivity in the area, or the Wi-Fi just wasn't stable enough. And of course, being able to go to somewhere to download a module and work at it from home is a real bonus. And every module has the resource to work through that they can download, print themselves, and so on. And it can be accessed anytime, anywhere, and returned to whenever they require. And that's been a big factor for people, is that they can't commit to a certain time. And that's been a real sort of standard response to people's ability to engage, or barrier to engaging, that we've seen for a few years now. So the story so far is that we went to the Health Hack. We pitched, we were successful. We went for a second pitch with the Welsh Technology Exemplar pitch, and we were successful there. But the budget to build a LMS, which is a learning management system, it's pretty significant. And I think we were really naive when we started this to think that we would be able to piecemeal together a little bit of funding here and a little bit of funding there. So we had enough to build 3 of the 10 modules. And we were going to hope that we could prove concept, and we could go out to maybe test the 3 that we had, and hopefully have some nice data behind us to go away and hopefully somebody would take it on as the further funding to complete the project. But come the end of December last year, so a few months ago, I was invited to talk to one of the directors of finance in the health board, who was interested in what we were doing and was wanting to help see this through. And that was, incredible, after having, almost, over a year, 18 months of sort of chipping away at this. We were eventually afforded some finance to see this project through. And I think it's just, again, it's a real tribute to Hywel in investing in initiative and innovation and seeing things from a really sort of a holistic way. So here we are, we're just about finishing development of the pain management programme in both English and Welsh. A labour of love for sure. In and out of studios, recording voiceovers, doing things, above and beyond really, and trying to keep a clinical work going as well. Has been a bit of a juggling act. We hope to go out to test functionality with a small group of focus group in April, May. We'll review and amend, and then we're going out to research and evaluate this whole package then as an LMS, with the support of Acceleration HCC to conduct that research. So really exciting few months ahead of us. A lot to get your head around and a lot to juggle, but really, really exciting. I think just in terms of potential benefits, increased choice, of course, for patients, increased access and flexibility, choice of language. They can click on the Welsh or click on the English and follow the programme through in their choice of language. And, it's good quality intervention. We've got the data to show that what we're doing face-to-face and virtually already is working, and it makes a difference to people's lives. So why not make that more accessible at an earlier point in time? And they can access it anytime, anywhere, and revisit, which is fantastic. For our service, as a clinical lead for the service, I'm looking at ways of being more prudent, of using my resource in a more effective way. And if I can reduce the number of face-to-face or virtual PMPs that we're offering at the moment by even 50%, I'll be releasing in excess of 300 hours clinical time per annum, which I can only imagine will make a huge dent into the waiting list that we have. So that'll be a huge benefit for patients as well. Travelling up and down the 3 counties is a big ask for people. And, pre-COVID, we were travelling to run these pain management programs 135 hours a year for clinicians to get there and back. And to think that, travel time is equivalent to something like 12 weeks of clinical whole-time equivalent, it's, it makes sense, doesn't it? And of course, the paper and printing and all of those things will save us money too. From a health board perspective, well, early intervention can only be a better thing. Better understanding of pain earlier on will hopefully reduce the need for unnecessary investigations and interventions being trialed, which then eventually people come back to us years and years and years later, which is quite frankly too late. It would increase capacity for secondary care services, maybe to see patients that actually do need that or would benefit from that type of work. And of course, the scalability of this could mean that it could be an income generator for the health board in time to come. And of course, there's always research opportunities to look at doing this. But I think more than anything, the project has demonstrated the implementation of a true values-based piece of work in practice, in service. And I hope to sort of think a little bit wider afield as well. The societal impact, the wider economic impact. So early intervention potentially less likely to develop unhelpful cognitions and helpful behaviours, pain behaviours. The impact for people's work and employment, childcare, families, all of those things could be, really improved with early intervention that is guided and supported from a clinical team. And building community resilience, just encouraging people to actually understand that they can manage this themselves with the tools, and we can give you the tools to do that. And of course, not travelling here, there and everywhere to appointments and hospitals and scans and everything will save time and travel and hopefully have an economic, environmental impact as well. And of course, last but not least, the scalability of the project. So whenever we think about Bevan exemplars, we think about them being as something that could be adopted and spread in the future. And I think this does have legs to do that. Hopefully this isn't going to be just for people living in Hywel Dda. There's no reason for it to be just for people living in Hywel Dda. And of course, we demonstrate the fact that it can be developed in 2 languages. So why not develop it in more languages if it works? And the potential to replicate the learning management system that we've now got for this into other long-term health conditions, it's a win-win, I think. Diolch. I rattled through it. I'm aware I spoke very quickly, but if you do have any questions, please use the links that Gwyn, I'm sure, will remind you of.
Fion, that was an excellent presentation, and thank you so much. And what another really clear example of how a small investment that the health hack initiates. So I accept your point there that down the line the project did need significantly more commitment and investment, but possibly at a point there where you'd already proven some of the value. So less of a risk to take in investing at those higher levels because the early stages had already been completed. Really excellent to see a presentation like that and a project like that that's been done with a small Welsh company, small Welsh creative company. It would have been so easy to take the project outside of Wales or to go somewhere where the economic impact wasn't demonstrated so clearly as well. So really great to see that partnership. Can you tell me, out of my curiosity, are the 50% who don't attend clinic, are they the same 50% that don't engage with live online, or are they a different 50%?
Who knows? I mean, they all attend. They are attending for their assessment, Gwen. So they're coming to clinics, and we're having conversations about, this is what would be, that this is the commitment from you, this is the commitment from us. Is this something that will work for you? And it's all yes, we'll be there, and really excited that this can be offered. And then they don't turn up. So who knows if they're the same 50%, because these are new cohorts all the time. We're constantly moving, we're assessing new people all the time, and then those new people get invited to the next run of the pain management programs. So they're not repeat offenders, if you like. They are new people every time that don't engage.
No, I totally get that, and I'm probably one of those repeat offenders as well. So I do understand it's for various reasons: socio-demographic, workload, personal resistance to engagement and all sorts of reasons, which you've demonstrated so clearly. So that really is, if you are nibbling away at that 50%, then you are clearly creating the opportunity for better outcomes at scale. Could you just tell us as well? It was your last point. I'd already written it down as a question, but you mentioned it very briefly in your last point. The opportunities to translate the learnings. To me, there seem to be learnings about the engaging the disengaged, but also learnings about purely the technical process of developing and transitioning to an online service. So are there plans to replicate and to share that knowledge?
Well, we'd hope so. I think the first part is to get our research study underway and evaluate that, because if that shows good outcomes, then of course there's absolute scope to do other things with this model that we've shown, hopefully shown it will work. There's plenty, I think Ciara has already mentioned, there's plenty of chronic conditions out there that really do require good self-management and empowering people to actually take responsibility for their own health, rather than that sort of top-down model that doesn't really engage people in the way that we hope it would. So absolute scope there to work, to translate metaphorically, but also translate literally as well, translate the work into other languages. Why not?
Excellent, especially once you've got a robust evidence base to do that from. Excellent. Thank you so much. My team have given me a nudge just to point out that James and Science and Engineering Applications Limited is also a Welsh company. So James is based on Anglesey. So that's 2 Welsh companies that we've had engaged with two health projects so far. So we're doing pretty well, 2 for 2. Phil, thank you so much. I hope you'll stay with us and engage with the chat. And I'm going to move on to the next presentation. But thank you so much. Thank you. Right, so next presentation, spectroscopic characterization of lung cancer sputum. So a great after lunch presentation I'm hoping for. A potential tool for rapid identification of malignancy. So hopefully Charlie Brilliant is online or on the way. Charlie is from the Centre for Health and Environmental Management Research and Innovation. So Charlie, are you there?
Yes, I am here. It keeps kicking me out and rejoining, but I think
okay, so we've got you, we've got sound.
We've got the last however long, and then it just did the thing. So, hello.
Hello, do you have slides, Charlie?
Yes, I do. I'll just share my screen. Can you all see that?
I think it just takes a couple of seconds to come through. Yep, now we've got it. So that's great. Excellent. I'll leave you to it, sir. Excellent.
Right. Well, thank you very much for the invitation to speak here today. It's very exciting, and it's been brilliant to hear about all the great work going on in Halvar and beyond so far. I'm Dr. Charles Brilliant, and I'm very pleased to present here on behalf of our team, led by Professor John Geen and Professor Paul Lewis. And we're just going to do a summary of our work on the spectroscopic characterization of lung cancer sputum. We've been collaborating together, Swansea Uni and Cwmtaf Maganrug UHB for a few years now. And some of you may have seen me give a similar talk at things like the HERW conference a couple of years ago. For those of you, this will serve as somewhat of a research update, some novel findings that we've undertaken in the last couple of years, on top of the previously presented work, as well as the future direction that we're going to be heading in. So I'll just give you a quick summary of lung cancer, of sputum, of our technology, and then I'll showcase our results. So lung cancer is a significant burden on healthcare systems within the UK and across the world. Specifically with the UK, we have approximately 47,000 new cases diagnosed each year, as well as 35,000 deaths. So it's quite a high mortality there. Survival for lung cancer is extremely low, at approximately 10% of all patients surviving for 5 years or more. The primary driver for this is late-stage diagnosis, when the disease has progressed and treatment is generally less successful. And this is illustrated on our next slide with this graph that I've borrowed from CI UK. It shows data from 2013 to 2017. The columns are the numbers of patients diagnosed at each stage, and we can see that stage 3 and stage 4 contain the vast majority of all cases, especially stage 4. And the dots represent the five-year survival for each stage. So you can see at stage 1, we have approximately about 50% survival rate, and you can contrast that to stage 4, where we have about 3% survival rate. So you can see that survival is highly stage dependent. There's also a significant economic burden for lung cancer within the UK. The full economic costs of lung cancer have been calculated to be about £2.4 billion per year. And this includes the potential loss of earnings by the patient and families, costs of unpaid care by friends and families, and costs associated with accessing treatments such as travel. This is approximately 15% of all of the full economic costs of all cancers to the UK, which is about 15.8 billion. And just as a point of reference, lung cancer represents approximately 13% of all new cases per year. So it costs slightly more than the proportion of cases, if all things were equal. So treatment costs for all cancers represents about a third of the full total economic costs at about 5.6 billion. And lung cancer is one of the most expensive cancers to treat. Each lung cancer patient costs the healthcare system about £9,000 annually, compared to 2,700 for bowel cancer, 1,500 for prostate, or about 1,000 for breast cancer. And the cost of treatment, again, is highly stage dependent. So the average cost of treatment for a stage 1 patient is about £7,900. Compare that to 13,000 for stage 4. And all these figures were taken from the reference you can see down the bottom right there. Okay, so I mentioned at the start sputum. So I'll just briefly describe what sputum, mucus, and mucins are. What it is, airway mucus is produced in all of us all of the time, but in respiratory diseases, the production of it is increased and usually results as a result of an inflammatory process. Sputum is produced when this mucus is coughed up from the airways, and that's what we're interested in, that coughed up mucus from the airways, and we go and play with that. Mucins, which are large glycoproteins, are responsible for the biophysical properties of mucus. They are made up of a protein core and are heavily glycosylated along the length of the polypeptide chain. And the expression and glycosylation of these mucin proteins is regulated by inflammatory mediators. And a hallmark of cancer, generally, not necessarily lung cancer, but a hallmark of cancer is an alteration of glycosylation patterns. Although currently there is not much literature on the glycosylation pattern changes of airway mucus or sputum in lung cancer. You'll find literature on changes to glycosylation patterns of biopsied tissue, but not necessarily expectorated sputum itself. So that was one thing we wanted to investigate. Just a little bit more background information for you. Here we have just some of the most common sugars that one may find in mucin glycoproteins. So we have galactose, fucose, galnac, glucnac, which N-acetyl galactosamine and N-acetyl glucosamine, and sialic acid. Oops, sorry. And generally, what you'll find is that in healthy mucus, mucins are glycosylated, but there are a few sialic acid residues, and there are a few sulfate additions to these chains. But after an inflammatory process, such as infection or something like that, you tend to find that there are more sialic acid residues, more sulfated residues, and as well as these Lewis X antigen moieties, more of these added to the chains as well. So we wondered if these structural modifications could be detected using a technology potentially in lung cancer. So what we need is a technology to detect these structural modifications, and that's where FTIR comes in. Fourier transform infrared spec is capable of detecting molecular structural change using infrared light absorption. So you shine infrared light onto your sample of interest. The bonds get excited and relax, and it's that excitation and relaxation which causes infrared absorption. And that absorption is detected by comparing a spectrum of absorbances of an unknown sample to a library of known samples, for example, a library of sugars and a library of mucin proteins in our case. We can characterize what an unknown sample, we can characterize the structures inside that unknown sample. I will say now that FTIR is not fully qualitative. The best we can do is estimate by comparing two known structures, two libraries. To fully say what's here, what's not there, you need to use another technology like mass spec. But the advantage FTIR has it is extremely low cost to run, requires no reagents or labels, very, very quick to run. You can have a sample in minutes, a spectrum in minutes, sorry. So some previous work that was undertaken by our group, this was a little bit before my time, back in 2010. They examined, or we examined a small cohort of cancer and non-cancer sputum cell pellet extractions. This was published by Professor Paul Lewis, where they identified 6 prominent wave numbers, and use that to distinguish lung cancer from non-cancer, which was encouraging, but it was a very small study based on just 25v25, and utilized a very complicated protocol to extract the cell pellets from the sputum, and then performing FTIR with liquid nitrogen and everything. It was not terrifically relevant to a not very translatable to a clinical environment. So what we wanted to do was undertake a further study with a simplified protocol and a larger cohort, just to see if we could still identify differences between cancer and non-cancer, but also to try and characterize the changes to the sputum specifically, not the cells. And that just these are just the aims of the study that we undertook, which is pretty much exactly what I just said. So here I've just broken down the methodology that we used. So firstly, you can see the patient cohorts. So we've got about 400 patients in this study. 214 of them are lung cancer, and you can see we've got varying histologies and stages within our cancer group, and we've got about 194 non-cancers, mostly made up of COPD patients, with a mix of exacerbation and non-exacerbation. But we've also got a small cohort of non-COPD, non-cancer respiratory diseases in there. So we took the raw sputum from these patients. It's just been coughed up, put in a tube, and frozen until we wanted to use it. So we took that sputum, very small amount of it, about 2 microliters, pipetted that onto a plate, and performed our FTIR analysis using a Bruker vertex, a picture of which is at the bottom of the screen. And then we performed two parts of our analysis. Firstly, trying to characterize glycosylation pattern changes, and then seeing if we could have some kind of predictive model that could identify signatures of lung cancer. So what we've got here is just some example spectra showing the mean cancer and non-cancer spectra, just to highlight some differences that we've seen between the patient groups. So what you can see is that there are some small shifts in peak position that are evident. For example, if you look in the top left spectrum, I don't know if you can see my mouse on the screen, but there's a small shift about 1653 to 1651 from non-cancer to cancer. And as well as about 1405. So we've got some small but significant shifts in peak position, but we've also got some differences in absorption, in mean absorption. So you can see within this region, from about 1200 to 900 centimeters, this is what is known as the glycosylation-rich region, which is where sugars generally have quite a lot of absorption. You can see that there's significantly less absorption within the glycosylation-rich region for the cancer compared to the non-cancer. And through a process of comparing absorbances and peak positions to known reference samples of sugars and pure mucin, and performing a curve-fitting analysis, we identified 34 distinct absorbance bands within the cancer spectrum. And sputum spectrum in general, I should say, 6 of which showed significant differences in absolute position. For example, one I've highlighted down here is at 1163, sorry, which is associated with those Lewis antigen structures that I mentioned earlier. So there's a significant shift in the cancer spectrum compared to the non-cancer spectrum. So this suggests that there's some sort of structural modification, whether that's more or fewer Lewis X antigens being expressed, or a change in their actual configuration, perhaps from Lewis X to Lewis Y potentially. But that would require further investigation to confirm, for example, by mass spec. Something which we are a bit more confident on is the reduction in absorbance in the glycosylation-rich region. Now that is indicative of a reduced glycosylation across the cancer mucins. We hypothesize that this is possibly due to shortened glycan structures coming about from the TN antigen, and there's a representation of the TN antigen on screen. So it's just a GalNAc bonded to either a serine or a threonine amino acid in the protein chain. And concurrently, along with the reduction in glycosylation, there also seems to be an increase in absorption at about 1740. And 1740 is well associated with the sialic acid residues. So it looks like that we have an overall reduction in glycosylation, possibly due to shortened structures, but with an increase proportionally of sialic acid residues. So we hypothesize that there are more sialic acid residues being found within lung cancer sputum. And this is supported by research that has found that sialic acid is found more commonly in lung cancer mucins bound to cell pellets, but not necessarily within.
So, Charlie, I just sorry to interrupt, but I'll give you a 2-minute warning.
Sure. Okay. No worries. I've only got a couple more. Great.
Thank you.
So basically, what that means is what we think could happen is an increase in sialic acid. We think increases the hydrogen bonding within mucus and makes it thicker and bind it together more strongly. And then, just in the interest of time, just blast on. So what we also did was have a look at potentially coming up with some models to distinguish between cancer and non-cancer. The characterization stuff is super interesting, but needs more work to really confirm that, and that's where we're going to hopefully go down a mass spec point of view. But this work here has the real translational value, where we think by showing a linear model, or just a simple model for distinguishing between cancer and non-cancer using a non-invasive and simple protocol, and that's what we've managed to do. So I'm showcasing one here as an example where we've taken the absorbances between two wave numbers, we've compared them. Cancer is green, is red, non-cancer is green, and you can see we've got separation of the two with greater than 85% specificity and 100% sensitivity. So we've developed a string of these similar models, all of them with excellent performance. Problem is that it was a retrospective study performed on samples with known outcomes, and the proportion of positive cancer cases compared to non-cancers does not represent clinical realities whatsoever, where the incidence of lung cancer is much lower. But we're very excited by this, because we think that basically, because it's a very simple technology, it could be implemented with not much effort into the healthcare system as a non-invasive and low-cost tool. But we need to fully evaluate that clinical effectiveness, and that's where our future work is coming in. So we've been spending quite a bit of time over the last couple of years searching for funding for a prospective further study that will address the limitations of the previous work and really push it forward in a valuable way. We're looking to have about 1,200 patients in primary care for statistical power to demonstrate a high negative predictive value for determining lung cancer, to fully establish that potential for early stage or pre-malignant detection by following up, but also to focus on the practicalities of implementing into primary care, as well as because for example, patient priorities with their perceptions on lung cancer and screening, because you can have the best screening tool in the world, but if no one attends, it's not the best. It's not very good. So we want to focus on that as well. Thank you for listening to me, and thank you for your patience with my rambling. I'm happy to answer any questions in the session afterwards.
Thank you so much, Charlie. And I was so glad to see that credit slide at the end. It wouldn't be a proper research presentation without all the credits and partners. So no, thank you so much for that. I'm going to move on because we're falling a little bit behind on time. But if you've got any questions for Charlie, then please, if you can put them into the chat, or you can contact Charlie through the Meeting Mojo platform, I hope, and you can carry on with the discussions there. So thank you so much for that, Charlie. And now I'm going to try and say hello to Julia Eads from Roche, Market Access Manager. Julia, are you there? Do we have you in the room?
Yes, I'm here, Gwyn. Can you hear me?
I can indeed. Yes, that's excellent. So perfect. Julia's presentation, Keeping Pregnant Women Safe, Opportunity to Collaborate on Innovation. And Julia, if you can pop your camera on, and if you've got slides, then...
So I believe you're doing the slides from that side, and I will just start my camera. If it's willing, no, it's saying failed to start on the camera. So I apologise about that. I don't know why that won't work.
Well, that's a shame, but we've got your slides up. Your slides are there, and we can definitely hear you.
And I definitely have not got my pajamas on or any of my relaxing clothes today, especially. So I apologize that my camera is not working. Okay, so hi everyone, my name's Julia and I'm the Market Access Manager here at Roche Diagnostics, and I specialise in women's health for UK and Ireland. And today, a little bit different from some of the other talks in this session, we're going to talk a little bit about what we can bring as partners to projects when working in collaboration with NHS, and really to show you an example of where that partnership and collaboration has been successful in improving the patient outcomes, so keeping those patients at the very centre of the projects that we work on. May I have the next slide, please? So in market access, and we sit in the wider team of access and innovation, we probably have a team that's a little bit different from the one that you may have interacted with at Roche Diagnostics previously. And what we do is we specialise in looking at innovations that have recently either come to the market or are about to come to market. And that might include things like changing the way we work. So it could be value-based healthcare, value-based procurement, and changing those pathways and the change management that underpins all of those activities. And what we like to do is try to include all the stakeholders, so anything from the health boards and the KOLs to patient charities and government and the NHS as a whole, to ensure that everyone is supported right through that change, keeping the patient at the centre, but then embedding that change at the end, because often we'll work on projects and they're fabulous and they work really well, but they're not, there's something missing that means they're not embedded in long-term care. And that's really what we try to do. And why do we do it? So I think that we all can think of examples where there's been great innovations that have come to market, but they've just fell flat. The uptake has perhaps been exceptionally low, and not because the innovation wasn't great, but because the change is difficult and it's very it's a big challenge to get all your ducks in a row, all your stakeholders to agree on making that change and actually doing it. So to support that, several of us are now certified change management practitioners, so hopefully we can help with that. And it's not just within Roche that we look at third parties, including digital solutions. So it's not necessarily to do with the core business of Roche Diagnostics. We will look outside of that, and indeed across the other Roche companies, so Roche Diabetes Care and Roche Pharma as well. So may I have the next slide, please? And what is the process we use? So we developed a model called Succeed. This is a brief overview of it here. And what this model really does is very early on, we get all the stakeholders involved. Each of the stakeholders, including us, will have clear and measurable actions at each of these points to drive forward the progress of the project. There's a lot of elements here that you'll be very familiar with and seen in other models. And what we found that is particularly important is that sponsor, to identify that key high-level sponsor in the programme. And once they're engaged and committed, what we have found is that it's a little bit easier. Nothing's completely easy, as we all know. Otherwise, we wouldn't need these models and change management. However, having something to work toward and work through, we found has really helped. And of course, looking at it in this way, it's just theoretical. So I wanted to take you through today a little bit of an example of where we've used this model and what successes we have achieved with it. May I have the next slide, please? So some of you may be aware of the Preeclampsia project that's currently concluding in England. And this was a project where we used the Succeed model and really sort of stepped back from what we would normally do and try and worked out that project plan from start to finish. So before the project started, we had 3 hospitals that were using the Preeclampsia test, which is a simple blood test which goes off with the normal preeclampsia bloods to the laboratory and looks at a couple of biomarkers that are indicative of the imminent onset of preeclampsia. And before the project, there was about 60 women per month were benefiting from this test. And If we think about preeclampsia, so about 2 to 3% of all pregnancies will have preeclampsia normally toward the end. However, about 10 to 12% of all pregnancies show some kind of sign or symptom that preeclampsia might be on its way. And the difficulty for the clinicians is how to identify those that will develop preeclampsia and actually those that won't, but will just stay with these few signs and symptoms that we can monitor and manage, but actually their pregnancy will, in all likelihood, make it to full gestation. So what happened before the test is, because preeclampsia is very difficult to predict, so it can go downhill very quickly, or actually you can just stay as you are for weeks on end. The clinicians will often bring these ladies into hospital for monitoring, and often they will come in for a day or so and then be let home, and sometimes they'll come back in, the same women, and other times they'll be fine and they'll go into community care. And what that does is that takes up a bed actually with somebody that necessarily doesn't need to be in hospital. It takes up some midwife time for monitoring. It takes up some tests that are sent to the lab for a person that doesn't necessarily need them. And really there's the adherence to NICE guidance DG23 had been quite low up until this point. And what were the outcomes? So I'm going straight to the outcomes. So we're at this point in time, we're at 110 hospitals are now using the preeclampsia test. And this is a project that we did with a competitor along with the Academic Health Science Networks and NHS England. So of the 110, 79 of those are Roche sites. And we're approximately 2,000 women per month now are having the test carried out during their pregnancy. And what that really means is that about 90% of all pregnant women in England can now access this test if they need it at any point during their pregnancy. And what it really means to the women is that they don't need to come into hospital unnecessarily. They can carry on with they may still be at work, or they may have other children, smaller children that they need to look after. And actually the impact on the women and the women's families is really huge if you can have a blood test and then carry on with the rest of your pregnancy without having to come in and out of hospital. And it's all about safety. We need to be able to safely send these women back into community or back home to carry on with their pregnancy in peace. And what that does for the system, of course, is that appropriate resource allocation. And just, I don't think there's probably any talks that don't mention COVID-19 at the moment. During the peak, particularly the first peak of COVID-19, what it meant was we were able to safely send home women so they didn't have to spend time unnecessarily in a hospital when we weren't sure what additional risk that was, when the obs and gynae were having to don and doff PPE because we were never quite sure who was infected and who wasn't. And that's quite unnerving for anyone, particularly pregnant women. So it was a good support tool to safely send those women back home. What we also did is we developed a whole toolkit for education. So that was education for the laboratories, for the obstetricians, for the midwives, but also for the patients too. So we have some agnostic tools that just talk about preeclampsia testing, not a company specific thing. And then long-term funding. So there was some funding initially from NHS England, but now we're moving into the phase where there is now ongoing long-term funding, and that has been obtained either by a local business case or via additional reimbursement from the local commissioner. And of course, as I mentioned, the patient experience. The patient experience has improved, and I'll show you some little quotes about that later. Could we move to the next slide, please? Okay, so how did we do this? We got together with the stakeholders and we thought about the Succeed model, and really it was all about what are those barriers? What are the barriers to moving the system to use in a product that has good clinical evidence, that has good health economics, but it's just not been adopted. And I think one of the biggest barriers was just change itself. And what that often means is that people haven't understood perhaps the benefit it would bring to themselves as a healthcare provider, to the wider system, but also to the women without breaking the bank. And I think we always have to be very mindful of that. But we should start with the patient at the centre and work everything around that. So we recognised that there was nice guidance and there was a nice health economics model, and that there was a lack of education. A lot of clinicians felt that they didn't have any issues with identification of suspected preeclamptic patients. However, then what we found was there were still significant numbers of women that were coming in for observation, but actually didn't at that time have preeclampsia and didn't develop it in the near future. So as I said, it was about the whole stakeholder engagement, lab, obs and gynae, innovation leads, and patient charities. The patient charity, particularly Action on Preeclampsia, APEC, were involved as well. We created new patient pathways. We had SOPs for both the laboratory and the obs and gynae department. So people didn't, when you're going from 3 locations to 110 locations, you don't want everyone rewriting or reinventing the wheel every time. So actually to really be able to share, freely share those tools and experiences between the locations worked very, very well. And there's the support with the individual business cases. Once we had the theory of the health economics, but once we were able to show it on your own patients, it had much more impetus when it went through the business case process. We worked really closely with the academic health science networks and the innovation leads within the hospitals, and leveraged against the national programmes and ambitions around baby and mother safety as far as we could. So those were the actions we took, and it was all framed around the Succeed model. May I have the next slide, please? So sort of what impact did it have? I think if the eagle-eyed of you would have noticed on the similar slide that I showed earlier, the average time for an innovation to be launched to adoption is about 17 years, which it's huge. So this test was launched in 2016, and then as of the end of last year, start of this year, we're up to almost full adoption. So this has taken between 4 and 5 years. So although as you're going through it, it does seem like a long time, actually the main body of that work has happened in the last 18 months. So it is much, much quicker than it would normally take. And also what we've been able to do is capture a lot of data and a lot of testimonials to underpin that project that we're able to share with across other projects, but across the preeclampsia project in other locations or other countries. May I have the next slide, please? So this is a case study that was written by Oxford Academic Health Science Network, and it's available on Oxford AHSM website. So this was regarding the benefits that they saw at the Oxford John Radcliffe Hospital by using the test. In addition, they also won the HSJ award for project partnership working for this project, along with Roche Diagnostics, the hospital itself, and the Academic Health Science Network. So it was a true collaboration that was recognised by the HSJ. And you can see some of the benefits that we mentioned here about capacity within maternity, about the patient benefits, and also that improved patient safety with the diagnosis and suspicion of preeclampsia. And may I have the next slide, please? So as part of this collaboration, we thought it would be pertinent to have a survey to really ask that question of our co-collaborators. What was it like to work with Roche? What benefits did Roche bring to this project? Were we beneficial to be involved? And just on the left-hand side here, this was the most recent one, which was completed in January of this year. You can see some quotes in a free text box in the survey of comments that our partners said about us. So this survey went to laboratory, obs and gynae staff, midwifery, and the academic health science network. And on the right-hand side, this was an article published in MedTech News last week, and Faye was a patient in Manchester. And this is just a little quote from Faye. And Faye had 2 pregnancies, both preeclamptic pregnancies, and during her first one, the tests weren't available. And then during her second one, they were. So she had a really good understanding from a patient perspective what it really means to have such a test available, and what difference it made to her in her pregnancies. Although the pregnancies themselves were almost exactly, there's no 2 alike, but they were almost exactly the same. But it really made a difference to her and her experience and how she felt about how she was being looked after and monitored. And that's the kind of feedback we get from the clinicians as well. May I have the next slide, please? So what next? I think really we want to identify opportunities to collaborate with you on a real partnership approach. Obviously, as the women's health person, and with the Preeclampsia project being a fully fledged, fully proven package that we can offer, this is something I'm going to lean towards because it's my side. However, we do work in lots of other disease areas, of course. At the moment, there's only one health board in Wales using the preeclampsia test. So the women are really missing out on something that can help them with their pregnancy, improve their safety and their experience. And Action on Preeclampsia, the patient charity that I mentioned earlier, has recently sent letters to the CEOs of all the health boards, but also to Vaughan Gething as well, just asking what the plans are, what the ambitions are to improve the use of the test and more adherence to the NICE DG23 in Wales. So hopefully we will be able to support and partner with moving that forward. However, in addition to that, we're really keen to hear if you've got any ideas or of opportunities or anything that with the patient at the centre can improve those patient outcomes and drive down those inequalities of care across the whole of Wales, but the whole of the UK. Just as this was a project in England that we're trying to bring to Wales, we'd like to do the same the other way too. So we have this dedicated inbox here, the Burgess Hill at Access and Innovation at Roche, but I'll also share my details on Mojo, so please feel free to get in contact with me. And yeah, that's it. If there's any questions, please let me know. I'm not sure if we have time, Gwyn. If not, I'll answer them when I get them. That'll be fine too.
Juliet, thank you so much. Thank you for a really interesting case study there.
You're welcome.
And I think one of the interesting things from my point of view is that you've obviously had a positive experience in engaging with the AHSN,
yes,
in particular the Oxford AHSN, and with the innovation leads in England. And whereas from what you were saying, your engagement with Wales has been through the chief executives and to the minister. And I'm just wondering whether there's an opportunity for us to connect you with the innovation leads and the parallel organisations in Wales, so that we don't have AHSNs in Wales, but we do have organisations who are tasked with similar functions, both in the innovation side and in the research side. So are you fully aware of the landscape in Wales in relation to research engagement and innovation, or would that be a benefit for you to talk about?
So I am aware, and I have had some engagement with the innovation leads, but I'm more than happy for you to introduce me further. And if any of them are on the meeting today, then please do contact me as well. And I think I suppose our ambition is to try and do something nationwide. you know, rather than piecemeal, which we do and we can do, but it's much more difficult to do one location at a time. But actually, if everyone gets together and we have that strength in numbers and we have that true partnership, then I think we can affect a much bigger change much quicker.
Absolutely, and I'm just thinking that there might well be colleagues from Health and Care Research Wales and from the Life Sciences Hub available as online today or during this week, who we can maybe help you connect with, who could pick up some of that engagement to try and get that all Wales approach. Juliet, thank you so much for your presentation, and I do hope you'll stay with us for the remainder of this session.
I will. Thank you very much for having me and giving me the opportunity to talk today. Thank you, Gwen.
Thank you. So now we are moving on to a team presentation, evaluation of the neighbourhood district nursery pilots in Wales. And hopefully we have Carolyn Wallace, Joe Webber, Rhys Roberts and Sue Pearce from University of South Wales and Prime Centre Wales, Aneurin Bevan, Cwm Taf and Powys Teaching Health Board respectively. So Izzy, if you've primed everybody to come online and to speak, then hopefully we're all ready to go.
Hi, diolch yn fawr. I'll just check to see my, Joe, are you there? You're on mute, and also Sue, you're on mute as well. Sue's there. Okay. I'll just, you're doing the slides, Gwyn, or are we doing them?
We can share them, or you can share them yourselves, whichever's easiest.
Well, you share them if that'd be easier, I think.
Great.
Diolch. Brilliant. Thank you very much. So, diolch yn fawr pawb. Thank you very much for inviting us here today. And my name's Carolyn Wallace, and I'm Professor of Community Health and Care Services at University of South Wales, and I'm also Associate Director of Prime Centre Wales. So in response to the connection discussion, I'd be happy to facilitate and introduce colleagues into Prime Centre Wales, should that be useful. I'm willing to pick that up. Just going on to our presentation, Neighbourhood District Nursing provides home-based nursing care to people living within a defined geographical area linked to a named primary care team. Neighbourhood District Nursing teams typically consist of registered nurses who have completed a specialist professional qualification in community nursing. These are usually team leaders, in addition to other registered nurses, healthcare support workers and administrative staff. They incorporate the principles of prudent healthcare, encouraging people to look after themselves and be responsible for their own health and well-being. They also support the public to lead healthier lifestyles and prevent ill health at individual and population levels. This 2-year neighbourhood district nursing pilots were funded by Welsh Government and commenced in April 2018. The evaluation itself is an example of how we all work together during a very challenging time for the NHS, so that we could provide a robust evidence base to transfer the principles learned right across Wales. We did this by conducting a realist review of the literature, document analysis, exploring patient stories, conducting interviews with staff and stakeholders, and exploring a range of service data collected by the teams during the pilot phase. And each of my colleagues, Rhys Roberts, Sue Pearce and Joe Webber, will be talking through the next slides and introducing themselves. That's me done. That one. Next slide, please.
Lovely, thank you, Carolyn. Hello, everybody. My name is Rhys Roberts. I'm the Interim Deputy Head of Nursing in Cwm Taf Maganwg Health Board, and I was the lead of Cwm Taf's Neighbourhood District Nursing Pilot. So very quickly following our Neighbourhood District Nursing Pilot, all of our lives changed very quickly through the COVID-19 pandemic. So every single facet of our district nursing service delivery was affected, but we were thankful that we had embarked on our neighbourhood district nursing journey, as we felt that this made us better equipped to deal with the challenges that lay ahead. Because of our neighbourhood district nursing work, we knew the requirements of our community much better than we did before. And knowing this meant that we could focus our interventions on the areas of greatest need to have maximum impact. For example, we knew that we had a large number of COPD sufferers in the Cwmtaf area, which immediately was a concern for us given the nature of the COVID-19 virus. Our proactive monitoring of these individuals during the pandemic was a source of comfort for these patients and helped them to maintain their own health during such an uncertain time. We also undertook some care aims training, which helped equip the neighbourhood district nursing staff to promote self-care in a time where physical care became extremely challenging for our district nursing teams. This training empowered our nurses to empower the patients to manage their own health in the best way possible. This worked particularly well with these with chronic conditions who were proactively managed through the pandemic by our neighbourhood district nursing teams. The key messages around encouraging self-care have never been more important than the last 12 months. What also aided our neighbourhood district nursing model was the use of e-scheduling tools. This had several key functions during the pandemic. First and foremost, recording and monitoring the COVID status of our caseloads, prioritising care for those who needed it most during the pandemic. It gave us the ability to respond to ever-changing demand in a fluid manner as well. So knowing the demand on our service allowed us to adapt our approach to suit the demand on our service. The e-scheduling tool also helped us manage the demand to match an ever-fluctuating functional capacity. Even this became very evident in terms of workforce when our workforce was depleted over the last 12 months. And now the scheduling software is helping us monitor vaccination status and ensuring the prioritisation of our caseloads is happening in line with Public Health Wales guidance. So in summary, the scheduling tool gives better visibility and understanding of our demand and capacity within our service, which then give opportunities to adjust our service delivery in line with this. Our challenge would have been far greater without such an e-scheduling system in place. Now, neighbourhood district nursing also gave us a more diversified skill mix, which was beneficial during the COVID pandemic. There were 3 areas of focus for our neighbourhood district nursing pilots. Skill development of non-registrants, so that's inclusive of our healthcare support workers and administrative workforce. Upskilling of our registrant workforce, and also the role of the advanced nurse practitioner. Ensuring our patients were seen by the best placed practitioners with a correct skill level helped to get the best value out of each contact in the community and maximise the potential of each contact. And it's clear to see that the COVID-19 pandemic would have been a difficult prospect altogether were it not for our neighbourhood district nursing development work. Okay, may we have the next slide, please? Is Joe with us?
It doesn't look like it, Rhys. Can you pick? Oh, yes, she is, I think.
We don't seem to have Joe on our delegates list in the room, so if you want to pick up instead.
Yeah, I can pick this up, that's fine.
Thanks, Rhys.
Bear with me 1 second, apologies for that. Okay, so the first thing that we learned on this journey very early on was the importance of learning the health needs of your local community. So all 3 areas involved in the pilot did some form of demographic analysis during the planning phase, which allowed for interventions to be tailored to local needs. Having a strong knowledge of local services or the local area not only instilled confidence in the patients and families that we served, but also helped us join the dots in a collaborative community effort to provide the best care to those in the community. Without this local knowledge and information, interventions would be less focused and have a reduced effect on the community. So just to expand on what I've previously discussed about our care aims training, so all 3 health board areas realised a substantial benefit from undertaking the care aims training programme. So as I said before, this training empowered our nurses to empower the patients to care for themselves. We tried to flip the balance in the community from district nursing teams providing care to empowering the patients to manage their own care in the best way possible. It gave the teams the confidence to adapt their nursing approach to suit the individual needs of each patient, depending on their needs and level of functioning. In many cases, this led to a mindset of proactive, preventative nursing. We stopped thinking, what can I do for you? And started thinking, how can I help you to look after your own health? This, of course, will produce better long-term health benefits and a community that has the tools to maximise their well-being. And number 3, the impact of the introduction of e-scheduling was felt by all involved in the neighbourhood district nursing pilot. It went way beyond being able to effectively plan our days. It gave us a better grasp of our service and the ability to forward plan, flex and adapt to match up the capacity of the service with the demand placed on it at any given time. This made us more proactive and less reactive as a service in our care delivery. So knowing where our workforce was out in the community, how we were progressing through our planned activity, this allowed us to be more responsive to any unplanned activity that came in throughout the day, with greater flexibility and focus to those in the greatest need. This, of course, had tangible benefits to patients, staff, and health and social partners around us. So in terms of patients, they received a better service. There was more transparency around their visits and better response times from the district nursing teams. And for staff, this had a profound impact on improving staff morale. It gave them more structure to their day and better information quality at the point of contact as well. And as I previously discussed, each neighbourhood district nursing area diversified their traditional district nursing staffing model in order to meet the individual needs of the community. The skill development of non-registrants, that's our healthcare support workers and administrators, upskilling of our registered nurses, and the role of the advanced nurse practitioners were all seen as a big success of the neighbourhood district nursing pilot. The enhanced skill mix in each neighbourhood district nursing area ensured the team had the skills to match the need of each local community. The neighbourhood district nursing pilot taught each area to think outside of the norm and gave us the opportunity to challenge traditional practice. This meant our communities were getting access to the right skill set when it was needed the most. And also the neighbourhood district nursing pilot gave each pilot area the opportunity to optimise the structure and support within their district nursing teams. This has allowed areas not only to become compliant with the Welsh Government announced interim district nursing staffing principles by getting their structure correct, but also to ensure the roles and responsibilities are clear and being undertaken by the right person at the right time. This has maximised the potential of the district nursing team to allow for optimal community care delivery. Okay, can we have the next slide, please?
Thank you, Rhys. Good afternoon. I'm Sue Pierce. I'm Professional Head of Nursing for Powys Teaching Health Board. And I'm going to talk about what the future now for neighbourhood nursing. So looking at the neighbourhood need, it's about nurses developing the public health skills to support and understand and use the population assessments and the GP data in collaboration with other members of the MDT and primary care teams. It's about changing the culture. It's around self-management and the patient being an equal partner with professionals. Rhys has talked about care aims, and it's about taking the care aims work further to work in partnership to further develop and broaden the understanding of the care aims, the decision-making framework and the alignment to NHS Wales strategic vision, to build on the principles and the associated benefits that are evident in the neighbourhood nursing evaluation report. And Rhys has alluded and talked about the e-scheduling tool, and the future regarding the e-scheduling tool we feel will provide a national opportunity to demonstrate the activity, the demand, the acuity of the people and the service that we're seeing. It allows us an opportunity to explore how we can develop the data, to utilise the data to develop a national data set across Wales which allows for benchmarking in a way to increase visibility and the contribution of the district nurse services. In addition, as anyone could have access to see the visits on the scheduling tool, it offers an opportunity for joint visits between professionals to add value and prevent multiple visits from different professionals, if that's appropriate. With the skill mix, this provides an opportunity, neighbourhood nursing provides the opportunity to explore different skill sets. One example being insulin competencies for healthcare support workers and what different levels of roles can offer, the understanding of each team member and what they can work at the top of their licence and the benefits and the risks associated with this. Empowerment of staff development and supporting and trusting multidisciplinary working. Integration is a mindset, the way we work well together for the benefit of our communities and our patients. Neighbourhood district nursing and the lessons learned, population health with a public health focus is the centre of the individual. There are opportunities to spearhead transformation that will truly deliver a healthier Wales. And that's it from me, thank you.
Here you can find the report with the ministerial statement, where the report highlights 8 recommendations for neighbourhood district nursing going forward. Diolch yn fawr, thank you for listening.
Thank you so much for that presentation and for the team approach. So can I just ask, so we're moving into a very different phase in where we're from COVID lockdown to COVID recovery. Do you just have any reflections on the immediate landscape that you're facing in relation to the work you're doing?
Yes, Gwyn, of course. As you can imagine, it's very, very different at the moment for district nursing services across Wales. We've had to adapt our approach significantly, in terms of conducting more remote management of patients at home as well. So there's definitely a lot of that happening in community nursing. In terms of the immediate aftermath, obviously, our neighbourhood district nursing teams have been heavily involved in the vaccination programme. So there's lots of work going on around that. And I think the tools that we've inherited as part of our neighbourhood district nursing pilot have helped us to meet that challenge. I think without those tools, we really would struggle, with the demand placed on our service at present.
Oh, thank you very much for that. And can I just say congratulations to you for making this, doing this work and moving forward in a situation where it must be quite a challenge just to deal with the day-to-day challenges that are being thrown at you. So congratulations to the whole team for doing that. So, and thank you so much for making the time to present today. Thank you.
Thank you very much. Thank you.
Thank you.
So I'm going to move on to our final presenter. Last but not least, and it's a presentation from the Wales Gene Park. How can we help you? So Karen Reid, who is Wales Gene Park co-director and operations manager. Karen, are you there?
Yep, I am here.
Excellent.
Good.
We have vision and we have sound.
Excellent.
So
thank you very much, Gwyn.
I will hand over to you.
So if I now press the share screen button, hopefully you can now see my slides as well. Absolutely perfect. Brilliant. Right, thank you very much. Diolch, and thank you for inviting me and giving me the opportunity to speak today. I am from Wales Gene Park, and what I wanted to do was to provide an overview of what it is that we're up to. But particularly ask the question of what other assistance would be beneficial to the MediWales community with respect to genetic and genomic support. So Wales Gene Park is an infrastructure support group. We're funded by Welsh Government through Health and Care Research Wales. And what that means is that we have some money to employ about 20 people, a small-ish sort of team, and we don't undertake the research ourselves, but we exist to support and also promote genetic and genomic research that's happening across Wales. Our structure is such that we have 2 areas of work, one around genomics for research, and the other one around education and engagement. And what I hope to do is to give you an overview of both and then invite questions and comments after that. So in our Genomics for Research area, we have a small laboratory team who can help and facilitate researchers access NGS technologies. So NGS, next generation sequencing, being able to generate genetic and genomic data from samples. NGS is routinely used in a lot of biomedical research, and it's got a range of applications. So at GenePark at the moment, we're supporting a lot of research projects that are using NGS to look at transcriptomics, to look at the RNA, what genes are being actively expressed in tissues. And these can be for samples that are both low input, so small quantities of RNA, but also to looking at a small RNA population. We can also enable researchers to access the technology for generating the sequence data following single cell sequencing. So we haven't got access to the machines to do the library preparations and the sample handling for single cell, but that is available through Cardiff University. But what GenePark can do, we can work with researchers to enable them to access that and then support the generation of the sequence data off the back of it. In addition to RNA technologies, there are also DNA applications, including ChIP-seq and HiC-seq, looking at the landscape, the chromatin landscape around genes and how the DNA is structured to be regulated. We can support whole exome sequencing or targeted panel sequencing. Indeed, whole genome sequencing, which the cost of which has come down significantly in recent years, or amplicon sequencing. And to back up and support that small lab team, we have a team of bioinformaticians who can do the important work of looking at and analysing the data that is generated from these sequencing experiments. And the bioinformatics team are well versed at using both DNA and RNA applications. They can do standard analyses or bespoke analyses for particular research projects, or they can provide training. And one of the things that's available through Wales GenePark is that researchers or anybody can hire Wales GenePark staff time for specific periods of time to enable the support for a particular project. So an example of a project that we have supported in recent years, one, we worked with Simon Reed, who was a professor within Cardiff University. And Simon is part of a team that have set up this company called Broken String. And they've recently received accelerator funding from Illumina to set up, and they're now operating in Cambridge. And Broken String is based on a technique called Induce-seq, which is a technique that is a disruptive technology that looks at DNA breaks or damage within the DNA. So before this company was established, we worked with Simon and the team to enable them to access the NGS technologies and sequencing that was needed to optimize this work. But he needed non-standard protocols, so just sending his samples off to some of the big international companies didn't suit his needs. But he could work with Wales GenePark, and we could use bespoke protocols to enable him to tweak what was happening, to optimize his procedures that will then enable him to gain further support and spin out to produce this company. So our bioinformatics team and data analysts are very keen to work with people. We have the SAIL data bank is based in Swansea University. It's a secure anonymized information linkage data bank and holds a variety of data sets around health and other sets of the population in Wales. And we are working with SAIL to establish the protocols needed to see the integration of genomic data into SAIL, or at least for project-specific work, the protocols that are needed to be put in place for that. We're also working with the NHS and All Wales Medical Genomics Service to see how we can exploit the data that's produced within the NHS setting and undertaking research using NHS data. And there's a keenness to explore how genomic data can be integrated with other data sorts for further research purposes. And the team are looking to apply a machine learning and AI techniques for these analyses. So in addition to the work around NGS, bioinformatics and data analysis, GenePark also have a very small team that are looking to support researchers to establish appropriate disease, preclinical models of disease. And they can do this by helping researchers establish patient-derived human iPS cell lines. They can do genome editing using CRISPR within these cell lines. We can work with people for collaborative funding applications in this area. And there's a research coordinator within Wales GenePark who can help support the governance that's needed around these areas to be able to work with patient-derived samples for research. So an example project that we have in this area is one with Celeste. So Celeste is a local biotech company that have a patented technique for bioprocessing and expanding human derived organoids. So organoids are three-dimensional tissues that kind of represent tissues from the human body. So they include a number of different types of cells in them. So they're not like 2D cell cultures. And working with Celeste and another academic research group, the Inherited Tumor Syndrome Research Group, Wales GenePark have been able to support a couple of successful funding applications, both CES2 for a PhD studentship, but also around a Clinical Innovation Accelerator Award that is using these patient-derived samples to grow organoids and to be able to use them as platforms for drug discovery or understanding the genetics of a disease where patients are predisposed to getting polyps, so cancer predisposition in these patients. The other area of Wales GenePark work then is around our education and engagement work. So we have a small team who are specialists, and they work to arrange a number of different events for different audiences. So the audiences might be for schools and colleges. They do a genetics roadshow. They organise a sixth form conference. They oversee a teachers genetics network and can organise career events or teacher CPD events around genetics and genomics. They can also arrange events for the public, including lectures and public talks or small community group talks. Again, they organise a public genetics network for people who are interested in genetics and genomics, and they organise an annual conference around genetics and genomics as well. Similarly, for healthcare professionals or indeed academic professionals who are working in this, the team can organise study days and conferences or workshops to ensure that the professionals are up to speed and are aware of the applications of using genomics within healthcare settings. They organise genomics roadshows and educational settings such as living with genetic conditions, where this is where patients or family members or carers of those who've got genetics conditions can come and talk about that lived experience to healthcare professionals, which is a very rewarding and valuable resource for healthcare professionals in that area. The team also organise events for patients with rare genetic diseases and their families and carers. So they can organise information days around different genetic conditions and support groups. There is a patient network that is supported, and we work very closely with Genetic Alliance UK and ensure that the patient voice is heard when working with Welsh Government and policy development work. So the Welsh GenePark team can help develop campaigns for different areas. So depending on your needs, the Welsh Gene Park Education and Engagement team can either offer opportunities for you to come and speak as guest speakers in pre-arranged events, or they can work with you to actually develop and host your own events, if that is of interest, as well as providing a route to connect with patients for patients to be involved in research and in policy development. So what's coming up, I thought I should mention this Genomics Showcase. It was meant to be held in the City Hall in Cardiff, but unfortunately due to COVID, it's had to go online. But this is on the, it says 14th of May. I've got a horrible feeling that should say the 17th of May. I will check that. But as part of this event, there will be a public zone in which there will be an interactive zone, so quizzes and DNA extractions, and careers advice around genetics and genomics. But it'll also be a professional zone, several parallel mini symposiums, poster presentations, and an exhibition area. So if anybody would like more information on this, or would like to take part or have a stand in there, please do register your interest or contact myself. The generic Welsh Gene Park email address is welshgenepark@cardiff.ac.uk. I thought I should also mention, if I've got time, Genomics Partnership Wales. So Welsh Gene Park is part of Genomics Partnership Wales. So in July 2017, Vaughan Gethin launched the Welsh Government strategy for genomics for precision medicine. And with that, there was funding for implementation of this strategy, and Genomics Partnership Wales was established to oversee the implementation. So it involves several partner organisations, including All Wales Medical Genomics Service. So they run the clinical diagnostic service within Wales. The Pathogen Genomics Unit, who are looking at pathogen genomics, and they've been run off their feet coping with the COVID pandemic of late. There are many other key strategic partners, including a patient sounding board. So we have a representation of patients and the public across Wales in this partnership. But Wales Gene Park is also one of the cogs in the wheel for Genomics Partnership with Wales. And our remit is to support the research environment and agenda. So thank you very much for listening. I am more than happy to answer any questions and provide more detailed answers to anything that you've got in query. As I mentioned at the start, I'd be very keen to hear if there is something that would benefit the community within MediWales that isn't offered yet, and that Welsh Gene Park can support this. You can find more information on the Welsh Gene Park website. We're also active on Twitter at Welsh Gene Park, and the generic Welsh Gene Park email address is welshgenepark@cardiff.ac.uk. But if you'd like to contact individuals rather than a generic email address, Angela Burgess is the person who heads up the public engagement work. So if you're looking at events or anything like that. Emma Hughes heads up the patient involvement and the policy work. And for pretty much anything else, you're welcome to contact myself. I'm Karen Reid, or reidkr@cardiff.ac.uk. So thank you very much, diolch, and happy to answer questions.
So thank you very much, Karen. That was excellent presentation. So I'm just noticing, so by the way, your showcase event for the online still says the 14th of May. So I'm
sure it is. I noticed on the flyer that it was on the 14th of May as well. It's just as I read it out, something went into my brain. That's not the 14th, it's the 17th. But no, it is the 14th. I won't confuse the whole team now. They'll kill me on that, friends. It is definitely the 14th of May.
Well, no one will forget it now anyway. So no, that's great. So one of the things I'd like to ask is just about the types of companies. You've mentioned engaging with industry, and you've given a couple of case studies of some companies, some small Welsh companies. So what are you working with any larger companies, or are there any larger companies, without naming names or being indiscreet, but are there larger companies that you would like to be working with? And you feel that you could provide with a collaborative R&D project with?
There aren't if I'm in all honesty. It's one of the areas at Welsh Gene Park I think we need to improve, is that collaborative working with large companies. We have had meetings and talks with some companies, the likes such as Roche as well. Gene Park can act as a gateway into Genomics Partnership Wales as well. So for some, like if you're running clinical trials and wanting sequencing on a large number of patients through a clinical trial setting, the way that genomics is set up in Wales, it's actually more beneficial for those partners to work more closely directly with the clinical diagnostic service who run the diagnostic for patients, as opposed to a research setting. But we're open. So if there are companies out there and they think actually what would really useful is X, Y, or Z, that's where I'd be interested to hear what's needed. So we've kind of developed what we're doing and responded to what's knocked on our door. So I know that several people have wanted that bespoke. So not doing your standard analysis, but doing something that's a bit different. And having the ability to have a staff member work on that dedicated project for an X amount of time to deliver results has been beneficial. But no, we're not working with the larger companies, but happy to hear from any.
Absolutely. Well, we'll see what we can do about that. We seem to be engaging more and more with big pharma and big diagnostics companies on the subject of data and accessing data in an appropriate manner. And I know that some of the partners that you put in your slide there, showing the whole network, are already engaged with with big pharma and big diagnostics companies. So it's obviously something that is in demand.
Yeah, and I think one of the companies, or some areas that we are working with companies, is around building that IT infrastructure that's needed to enable the integration of genomic data with other data sets in a secure way. So that I'm not, that's not my area of expertise, but we do have collaborations with some companies who are looking to help establish and grow the IT within Wales that's needed to drive this forward.
Okay, excellent. Thank you for that. I'm just checking the chat as we're speaking, and Alan Thomas has mentioned your genetics cafe this morning. Was that?
Yes, so I wasn't at the genetics cafe. It's been a busy day for Welsh Gene Park today, but the genomics cafes are held in collaboration with Genomics Partnership Wales. But these are an excellent opportunity where the public and patients can come and hear the latest topics. So there was a range of speakers. So they're held regularly throughout the year, and they've had great attendance. The idea was initially that they were held in person, and that we'd go to North Wales or West Wales or whatever and facilitate these cafes, and then provide a local organizer with the tools required to be able to facilitate those cafes ongoing. But with the pandemic, face-to-face meetings couldn't happen, so they've all moved online now and are virtual cafes. But as such, we can have a broader audience attending them.
Definitely. We're all in a different place at the moment. Not for too much longer, one might hope. But yeah, we're all in a different place, and we're doing these things digitally. And that does actually mean that we can engage with a wider variety of people from a wider geography. As it's not quite the same the same as meeting face to face, but we're all making the most of it. So
indeed, yeah. One of the things that we're hoping going forward is that we'll be able to have like a mixed model. So some of our events will be able to happen in person, and then we'll probably, I think the virtual platforms are here to stay, so that it will always be an element of that going forward as well.
Absolutely, same for us too. Okay, thank you very much, Karen. That was a really interesting presentation. Right, thank you. So it's my job to draw proceedings to a close. Thank you so much to all of the speakers we've had this afternoon, and all of the speakers we've had today. I think we're up at around, if not quite 20 speakers, but very close to it. So a huge effort has gone in today, and we really do appreciate it. And we've had a great audience as well. So a really strong day, an opening day for Connects, but not the by no means the end. We are we're moving on to we're spreading Connects over 4 days this year, partly because usually we would do Connects in 1 day, but we find that shorter sessions spread over a longer period is probably the way. As we were just discussing, that we're changing to digital formats. One of the lessons learned is that people need breaks in between their digital sessions. So please join us again tomorrow. We've got 4 sessions tomorrow, and I'm struggling to. You might hear in my voice that I'm struggling, but I am actually struggling to put them up online at the moment. So I'm going to ask Izzy to make sure that in fact I can see that Izzy has put the program in the chat. If you go to the beginning of today's chat, you'll see that the program for tomorrow is there. We've got 4 presentations, and we've got value-based healthcare presentation. We've got we've got procurement, and we've got a regulation session in the afternoon. I would suggest that sometimes regulation can be a bit daunting for non-regulatory people, but whether that's industry people or clinical experts. But if you are in a clinical setting and you have a product or a process and you don't know where to start in terms of regulatory compliance, please do attend that meeting tomorrow afternoon, because we have got experts in the room who are there and ready and waiting to answer questions. So if you're on that journey, so one of those journeys that we've heard so much about today, and you would like to hear a little bit of advice or guidance about the regulatory pathways, and then please do join us for tomorrow. So great presentations for tomorrow, and you've got a little bit of homework as well. We've mentioned it once or twice, but you will have had an email as a delegate to the Meeting Mojo partnering site. So please do take a look at the email, have a click of the link, and log into Meeting Mojo, and if you put your profile in there, then you'll be able to see other delegates who've also put their profiles in there, and you can arrange one-to-one meetings online, obviously, but a bit of online face-to-face one-to-one meetings as part of this week's program. One more point, in the chat, you'll notice that I've just posted a link to Life Stories. Now, Life Stories is the MediWales annual magazine that we produce in collaboration with NHS Wales, academia and Welsh Government. So it's the academic, the business, the clinical and the government partners. But essentially it's a case study magazine. It's just pages and pages of examples of case studies of people who've been through the pain. They've done the research, they've done the innovation, they've done the product launches, and these are the examples of those projects, so that we can all learn from successes, but also learn from challenges. So there's your homework. Check out the program for tomorrow. Make sure your profile's on Meeting Mojo, and if you've got any energy left, then make sure that you have a look at the Life Stories magazine to see the other case studies. So finally, can I just say thank you so much to Isabel, who's been in the background for today. We've got a team of Izzy and Sam and Katie who've been managing social media, technical side, and the chats, and they're with us for the rest of the week. And then we also have Debbie, who most of you will know, who put the speaking program together, and Debbie will be available online and on chat as well throughout the week. So if you'd like to talk to any of us, please drop us a line, and I will leave it there. Have a lovely evening. The weather's not too bad, so get some fresh air, and we will see you all tomorrow. So thank you very much.